Hello, it is Ryan, and we could all use an extra bright spot in our day, couldn't we? Just to make up for things like sitting in traffic, doing the dishes, counting your steps, all the mundane stuff. That is why I'm such a big fan of Chumba Casino. Chumba Casino has all your favorite social casino-style games that you can play for free anytime, anywhere with daily bonuses. That should brighten your day a little. Actually, a lot. So sign up now at ChumbaCasino.com. That's ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.
Hey all, welcome back to the Real Life Pharmacology Podcast. I am your host, pharmacist Eric Christensen, and I thank you so much for listening today. As always, if you haven't signed up yet, go check out reallifepharmacology.com. We've got a top 200 study guide. It's the 31-page PDF, a lot of material there, and great resource. If you're just looking up to brush up, on some of the most important clinical pearls of those top 200 drugs, or if you're taking, board exams, finals exams for pharmacology, great resource just to brush up on things. So absolutely free, no cost to you, simply for following the blog. And we provide updates when we've got new podcasts available, new content available, and things of that nature. So again, Real Life Pharmacology, go check that out. If you want to track me down, comments, suggestions, things like that, definitely reach out to me, mededucation101@gmail.com, or I'm probably most active on LinkedIn. So Eric Christensen, PharmD, BCGP, BCPS. All right, so let's get into what you guys came here today for, and that'd be escitalopram is the drug. And brand name of this medication is Lexapro. I have covered SSRIs in general, but wanted to dig a little bit deeper, specifically on escitalopram. So mechanistically, this drug is an SSRI, so selective serotonin reuptake inhibitor. I talked a little bit more about that mechanism in the SSRI section previously, so go check that out in general there. Dosing on this medication, usual starting dose, or the most typical starting dose I see is 10 milligrams. In the patient population I work with most, geriatric patients, I have seen it started at 5 milligrams, just being cautious and conservative. And again, that may depend upon what the patient is taking. So if they're on maybe other medications that have, mildly serotonergic activity, maybe they're taking a low dose of tramadol or something, maybe we'd want to be a little bit more conservative in that situation. Another situation that might, necessitate more conservative dosing, maybe they've been on other SSRIs in the past and didn't tolerate them for some reason. So there are definitely, clinical reasons why we might be more conservative versus less conservative. Indications, depression, anxiety, certain eating disorders, OCD, lots of different psychiatric indications that escitalopram can be used for. Of course, we carry that boxed warning for all SSRIs, the increased risk of suicidal thoughts, particularly associated with younger patients and adults. Adverse effect profile. So this is, I think, as you gain more understanding of the class of SSRIs as a whole, there's going to be kind of subtleties between each of these agents. And particularly with escitalopram, we think about activation versus sedation. So in the scale of SSRIs, I think about fluoxetine being the most activating typically, while the most sedating SSRI probably tends to be paroxetine. And I would say escitalopram kind of falls right in the middle there of maybe being neutral, maybe a tiny bit activating. Again, dose can matter, and patient response can matter. We can have patients report either activation or sedation. But in general, I would say it kind of falls in the middle range there. of sedation and activation. Another thing to potentially consider, remember escitalopram is an enantiomer, the S enantiomer of citalopram. So you can think that they're probably going to have somewhat similar profiles. And with that, QT prolongation is well reported with citalopram, and it is something that I think about with escitalopram as well. Sexual dysfunction, definitely with all SSRIs, this is something I think of. And if I see a patient, let's say, taking an erectile dysfunction drug, such as, your sildenafil, for example, or tadalafil, I definitely look and see what other medications they're on, and if they are on an SSRI or other antidepressants that cause sexual dysfunction, that's certainly something to look at and assess and think about if we can actually do anything about it. GI upset, certainly can happen with the SSRIs in general and escitalopram. On the scale of how significant of GI upset or diarrhea does it cause, I would say it's probably in the middle range. Again, thinking about our other SSRIs, so sertraline probably tends to be the most diarrhea-inducing or stomach upset-inducing, whereas paroxetine probably tends to be more on the constipation side of things due to its anticholinergic effects. So with that said, escitalopram would probably fall somewhere in the middle there in general. But again, you're going to want to look at the timing of when citalopram was added, potential dose escalations that may contribute to an increased risk of adverse effects as well. One really important patient education point that you need to go through with patients is that these drugs take a while to work. I've seen numerous cases in clinical practice where patients maybe encounter some mild discomfort, some mild adverse effects, and they stop taking the medication because they don't feel like their depression or whatever we're treating has gotten any better either. So these drugs tend to take weeks of time to start providing benefit and to provide that improvement, again, in whatever you're treating, anxiety, depression. It takes a while to work. So very, very important patient education point there. All right, so I'm going to take a quick break now, and we'll finish up with drug interactions. If you're in the market for pharmacist board certification study material, definitely go support our sponsor, meded101.com/store, STORE. All the resources there help benefit the podcast, help keep it free and educational for all to enjoy and benefit from. We've got common resources, books on medication education in general for anyone from a nurse to a nurse practitioner to a med student, physician, and of course we've got board certification study materials for pharmacists as well. So go check all those resources out at meded101.com/store. Help support the sponsor, which obviously helps support me and this podcast. All right, so let's finish up with drug interactions. So from a metabolism standpoint, when I think of escitalopram, I think of CYP2C19 and CYP3A4. So those enzymes do break down escitalopram to a certain extent. Now, would I say it's a crazy extent? No. But would I say that, it can potentially alter the activity and concentrations? Yes, I think there is some significance there. So CYP3A4, we think about, enzyme inducers like rifampin or St. John's wort or carbamazepine. Those can potentially lower concentrations and drug activity of escitalopram. CYP3A4 inhibitors can obviously do the opposite, potentially increase the risk for elevated concentrations. CYP2C19, again, another pathway there. Classic example is omeprazole. Omeprazole potentially has some inhibitory effects on CYP2C19, so concentrations of escitalopram can potentially be elevated a little bit there. Of course, with that omeprazole interactions and increase in concentrations, we do think of QTc prolongation risk with escitalopram, just like we would with citalopram. I would say there isn't as great of a body of evidence for escitalopram as there is for citalopram, or brand name Celexa. But it is something we need to look at. What does their EKG say to us? Do they have other risk factors? Are they on other drugs that can interact and raise the risk for QT prolongation? Thinking about some of those agents, your amiodarones, your quinolone antibiotics, your antipsychotics, those are all meds that could have additive effects on QT prolongation. Other agents to think about, so if we've got other psych medications on board, TCAs, MAOIs, SNRIs, that's probably not a combination we're ever going to want to use together. With that said, I have seen those combinations before, and in general, it's not appropriate. And I would say in most situations where I've seen, let's say escitalopram on board, with a TCA, often we're transitioning or trying to transition off of one to another for whatever, the purpose may be, whether that's, neuropathic pain or fibromyalgia or whatever the case may be, or the indication. So that's important to think about, that additive serotonergic load and, of course, risk of serotonin syndrome. A couple of others that may come up as far as drug interactions go. Hyponatremia, so all SSRIs can do this. So think about some of your diuretics, thiazides, things like that, oxcarbazepine, carbamazepine. These are all drugs that can contribute to SIADH and hyponatremia, and we could potentially have additive effects when we start to add on more and more medications that can do this. And then one last thing that does come up occasionally is bleed risk. I don't think it's a huge issue for most patients. However, if you've got patients on, anticoagulants, antiplatelet medications, your heparins, your DOACs such as apixaban, rivaroxaban, there is potential that SSRIs and escitalopram specifically here could slightly raise that risk for bleeding. So when I see patients on both, and it happens in clinical practice quite a bit, where patients are on a drug like escitalopram, with aspirin or, with an anticoagulant, I assess that patient for bleed risk. Are they anemic? Do they have bruising? Have they reported bleeding in the past? And from that, we've got to weigh that risk versus benefit of, how beneficial has escitalopram been, and, what other potential medications is this patient taking that may increase their risk of bleed as well. So, again, it's not an absolute, contraindication where, we can't use escitalopram in a patient that's taking a medication that increases the risk of bleed. But it is something that I take a peek at and at least look. And if they've got a substantial bleed history, I'm definitely going to, look at that and at least start to assess what is the risk versus benefit of looking at the SSRI, as well as looking at the other medications that may induce that bleed risk as well. So I think that's going to wrap it up for today. Thank you so much for listening. If you've found this podcast beneficial, leave us a rating, review on iTunes or wherever you're listening. Also take the time to support the sponsor, meded101.com/store. Take advantage of the free audiobook that Audible gives you if you've never done that before. Again, you can find links to that at meded101.com/store, S-T-O-R-E. If you want to track me down, suggestions, comments, definitely reach out to me at mededucation101@gmail.com, or you can find me on LinkedIn as well. And of course, head to reallifepharmacology.com, sign up, snag your free 31-page PDF on the top 200 drugs. All right, well, I thank you so much for listening. Take care. Have a great rest of your day.
Judy was boring.
Hello.
Then Judy discovered ChumbaCasino.com.
It's my little escape.
Now Judy's the life of the party.
Oh, baby, mama's bringing home the bacon.
Whoa, take it easy, Judy. The Chumba life is for everybody. So go to ChumbaCasino.com and play over 100 casino-style games. Join today and play for free for your chance to redeem some serious prizes. ChumbaCasino.com.
No purchase necessary. Void where prohibited by law. 18+ terms and conditions apply. See website for details.